yeah, we'll just go from there.
Go Beans.
8. And yeah, we'll just go from there.
Excellent. Go Beans.
All right, so 8. Okay, this is really weird. It's literally...
I know, I can hear the double.
Okay.
It's gone, I think.
I just closed the tab. That's fine. All right, yeah. So we'll just start at 3 o'clock and wait for people to join.
Awesome.
All right, we'll give it one more minute for a couple more people to join, and then we can start. Okay, so it looks like a couple people joined, and I'm sure a lot more people will start trickling in as we go. But so welcome, Dr. Katie Kline. Thank you so much for joining us. Dr. Katie Kline is a nurse, and she will be talking about her experience and giving her medical message today.
Perfect. Well, let me go ahead and I'll do a little screen share. And I am super flattered, but I'm not Dr. Kline just yet. Maybe one day. Right now, I'm just a registered nurse, and I have a bachelor's of science in nursing. Hold on a moment, just figuring out how to share my screen right there. Perfect. How does that look? Awesome. So becoming a pediatric nurse. Let me actually make sure this is the right one. There we are. That's more like it. Okay, technical difficulties out of the way. So my medical message with you guys, no presentation is complete without Bitmojis in 2020. So just a little bit about myself. Again, I am a bachelor's prepared nurse. I'm certified in pediatric critical care, and I am currently celebrating 5 years as a nurse. So what a bachelor's of science is it's a 4-year nursing degree. There are several other options for students to become a registered nurse. However, that is the track that I decided to take because I not only decided I wanted to go to a 4-year college, but I also was very interested in playing sports. So that's kind of what drove me along that track. So I did end up going to a private institution, played sports, was very active in student life, and was able to also obtain my nursing degree within 4 years. now I am celebrating being a certified pediatric nurse, and to become certified, it requires X amount of hours and time practicing in a critical care setting. There's a examination period that you undergo, and then from there, you can obtain your certification if you pass that test. So I'm celebrating almost 2.5 years of being in the ICU. Before that, I actually was in the pediatric operating room. And that is kind of where it sparked my interest in transferring and doing critical care. But currently, I work at a level 1 trauma center, an educational healthcare system. And what that really means is that we support a lot of new and aspiring healthcare professionals. There is a nursing school associated with it and a medical program as well. We see a lot of residents that are doctors that are done with their medical school and now going on to receive specialized training. And then even further down the road, we have fellowships available to doctors after their residency that have accepted a fellowship in a certain area or specialty of medicine. So we are very well versed in educating medical professionals and really work our healthcare system around cultivating, the next generation of medical professionals. So that's just a little bit about me and kind of where I work. Let me see what's going on. Awesome. So as far as where I work within the healthcare system, many of you might not know what the pediatric ICU is. The picture, this is a very empty ICU room. These are kind of like the beds that I use on a regular day. But the room itself is pretty empty from, as far as the monitors go and the things that are in them and what we use to monitor our patients. So in the PICU, we actually take care of critically ill children. Typically, they're anywhere from like 0 days old to 18 years of age. We do sometimes flex up to 21 years of age, but in recent years, that's very far and in between that we do that. Most of the time, our common admissions have to do with respiratory or cardiac failure. Those are two very prevalent things that happen with children. And basically, they just need very close observation, monitoring, and sometimes intervention with those. So we have cardiac admissions for surgery. We have respiratory failure. So sometimes like the child that comes in with an exacerbation of their asthma, or they could have, a flu, some sort of flu-like picture where their respiratory tract is severely compromised and they need mechanical ventilation. We also have neuro patients, so kids that come in might have seizures or might have a reservoir in their brain that allows fluid to drain from that area. We take care of a lot of those post-operative patients. We also have a very extensive cardiac surgery program. So children with congenital heart defects, we are often responsible for their pre-op care and management. And then after they go from surgery and they come back to us, and we're responsible for caring for them and de-escalating their care after that. So big surgery program. We do get the occasional trauma where we're responsible for them. And then children that have any sort of acute or chronic renal failure, those are also kind of prevalent for admissions. But what keeps me coming back to the PICU is really that children are so resilient. I have never experienced a more positive work environment. People really care about what happens to these children and actually making sure that they have the opportunity for a brighter tomorrow. So just working here in the 2.5 years that I've worked within this specialty it's been a great experience for me as a nurse in my career. And I feel like I learn something new every day. So just being able to serve that population at their most vulnerable points has really just given me the greatest purpose in life. But moving along, I got a lot of questions as far as, what's a day in the life like for a registered nurse in the pediatric ICU. No matter what, I work 36 hours a week plus some. It just depends on if we're short staffed and if I'm available to pick up. But we do have weekend requirements. There is holiday requirement as well for working. So we kind of lump those and are very transparent about like what holidays you're supposed to be working, and oftentimes rotate those or flip flop with people if we need a certain one off. So it's pretty flexible. But for the most part, I schedule myself from when I'm available, which gives me a very nice work-life balance. If I need time off, I can most of the time schedule it without having to use paid time off, which is great. However, I rotate days and nights right now. I have to say that I do prefer night shift a little bit more, and that's just because of the flow. And I'll kind of get into that. So if I'm working, no matter what, if it's a day shift or a night shift, typically I'm up at like 4 a.m. or 4 p.m. on any given day that I'm working. I take time for myself and make sure that I'm taken care of. I work out pretty early in the day. By 5:30, showering and just getting my things ready to get to work. And then by 6 o'clock, I'm mostly out the door. I don't leave any later than 6:15, so that I have at least 15 minutes before my shift of looking up, who's my patient, what's the acuity like, and if there's anything that I need to be aware of as far as like big players that are on our unit. So at 7, that is our shift, our big like board report, shift change. So the charge nurse from the shift before has a list of our patients and makes a copy for the next shift, and the charge nurses for our next shift. And we just kind of go over each of those patients, just a little brief synopsis. How did their shift go? What do they need from us? Is there anything that we need to be concerned about? And that's just so that, we know something about each of those kids in case of an emergency. I could help. I could be a team player and help in an emergency situation. It also helps us mentally as a team build, who's going to need the most help on our shift and how can we support them best. So as far as days versus nights go, the daytime is more procedural. We're changing a lot of what their care plan is, and really talking with different team members that are consulting on these patients, because most of the time it's not just our ICU team that's managing them. We'll have cardiologists come in, we'll have renal specialists, things like that, that are more well versed in that area of medicine, come and just consult on these patients. So all of the care plan changes for the most part are made during the daytime hours. We do a lot of bedside procedures. So if we have line placements or line insertions, that's typically when we want to do them, because then we have extra hands around in case, something were to happen. We transport our patients around to like maybe CT or MRI, and sometimes take them to the operating room pretty early in the day. And then on daytime, we're just trying to get them through their day, and still support them as children. So making time for play, getting up out of bed if that's possible for them, playing, involving child life, physical therapy, occupational therapy. So the tasks that go along with day shift, sometimes they can really add up. We also need to allow for those naps in there, just so that they have a break throughout the day. On nights though, it's a little, the intentions shift a little bit. We're very big on sleep hygiene, and that's just to focus and make sure that our patients don't experience ICU delirium. And to kind of explain really what that is that if you take a child and, you take them out of their normal environment where they might be at home, in a place that they're familiar with, and you introduce them to the ICU where there's new people, random noises, like they're up at all hours of the day being poked and prodded, and things are being done to them. That can be very, very off-putting, and it can be very detrimental to not only their physical well-being, but also a little bit of their psyche. So a kid that's delirious, they oftentimes won't really respond to our assessments. We could wave our hand in front of them and their eyes really won't move or adjust to us trying to get their attention because they're inattentive. So we do a lot of focused physical assessments and interventions, even though I might have medications planned throughout the night that are due at certain hours. I still try to be cognizant of lumping those things together so that there's restful periods for that patient. They're able to stay on a nighttime sleep schedule and not be bothered. But again, that's not always the case. Sometimes, we do have to intervene with them if they're not stable. So, but what is guaranteed in a shift is the nursing process, which is shortened to 80 pi, but we're assessing, we're having our nursing, we're evaluating our nursing diagnoses for these patients, planning the shift for them, intervening and doing things for these patients, and then evaluating those interventions on them. So it's just a continual process, especially in the ICU. We're always, always, always assessing. We also closely monitor their ins and outs. So whatever is going in this patient from like a medication standpoint, if they have drips going or maintenance IV fluids or feeds, we're monitoring and tracking all of those and their volumes. And then as far as output, like are they peeing? Are they pooping? Is there anything coming out of their NG tube? Things like that. That's very, very important, especially in pediatrics, because it can really affect their care if they're fluid overloaded or if they're dehydrated. Those things, we want to keep them kind of at a nice euvolemic, depending on what their underlying diagnosis is. We're also throughout the shift administering medications. Sometimes that's going through an IV in more of a liquid form. Sometimes it's oral medication. It really just depends. So we have a pretty intense background in pharmacology and how to administer those properly and the things that we're looking for as far as side effects. And then, of course, charting and documenting. We are always continually charting changes in our patients so that when our physicians come and look, they can physically see trends in what's happening with the patient, their vital signs, their fluid status, so that we can formulate a better care plan around what they need. We do a lot of education because no parent wants to, not know what's going on with their child. So we really try to sit down, meet them at their level, and explain what's happening with their child, what's the plan in place, and what is ideal for them, and how we're going to meet them along the way and progress them so that at one point they're hopefully not going to be in our ICU. And so that's met with several challenges of its own, but a lot of the time, it's up to like our nursing staff to really advocate for our parents and what they're expecting. So, it's just a continual process back and forth so that our parents feel supported and that our patients are receiving the care that they need to have successful outcomes. So that's kind of a day in the life. By 7:15, I'm giving report to the next nurse coming on, and hopefully by 8, I am out of that unit. That is always the goal, because most of the time I string my shifts together. I try to do 3 in a row just so I can be in and out for my requirement for the week. But sometimes that just depends. So that's kind of what a day in the life is like. If anybody had any questions about that before we got into the case study, I feel like this is a good opportunity to ask while it's fresh in our mind. So if you have questions, please drop them in the comments. And I got one from, I can't see who it's from, but it says, are you ever on call or held overtime? So yes, we do have a call schedule. It's up to you to sign up for additional call if you want it. However, it's not mandated. And so there isn't a pay incentive for that. And as far as being held overtime, the instances in when that happens, they're kind of few and far between. Um, we have an excellence, in care for our patients. And sometimes, unfortunately, a patient is just not stable at shift change when we're trying to give report and hand things off with the oncoming nurse. And sometimes it does take a little while to get out of there. So you do end up being held overtime a little bit. But as far as like not having somebody to give report to because somebody didn't show up to work, that doesn't really happen. Like typically you're able to get out of there. And in the instances that I'm not able to get out of there on time, I don't mind because the safety of that patient is my number one priority. And it happens like pretty infrequently that I would get. So I hope that kind of answers that question. Sorry, I'm just trying to look at where the little chat is. How busy is my schedule on a weekly basis? So on a weekly basis, I'm working 36 hours a week. So that is 12 and a half hour shifts, just 3 of them. So it's not very busy. However, if you string 3 in a row, you're never guaranteed the same patient back. And especially in my position, I've been there for quite some time now. I have specialty training to do TCV, which is thoracic cardiovascular. So that means that I recover a lot of our post-op heart patients. I'm trained on how to do continuous renal replacement therapy, whereas some of our younger or newer nurses might not be. So it really just depends because sometimes in those three shifts during the week, you could get pulled to do so many things. So it can get pretty tiring pretty quickly. But as far as just my schedule, that's why I normally don't sign up for extra unless I need to make a little bit more money for some reason or another. I typically keep it to my 3 shifts a week, and that's just part of my work-life balance. But I really did enjoy working with children before I went into pediatric nursing. Back in high school, while I was really involved with sports, I also would help host, clinics for children to get them into field hockey or running track. And when I was not in school, during my nursing school period, I was home for summer break. I actually worked with my brother-in-law in a functional life skills classroom. So I got to, work with children with developmental needs. And, I just think I have really always enjoyed working with children. They're super resilient, super fun, adorable. So giving them the opportunity to, get better has definitely, I think, been the easiest choice in my nursing career. But as far as how long the journey was from me in high school to getting here now, that was 4 years of nursing school, about 2.5 in the operating room first, and then after that I'm here at about 2.5, so 5 years. That's adding all of that up, that's 9 years of work to be where I am sitting talking to you guys right now. So, but every year was definitely worth all of that. So, are children more tiring to work with as compared to adults due to the fact that children don't understand everything you're trying to explain to them? So it's true. They can be a little bit more tiresome just because They don't, but we have access, at least at my hospital, to child life therapists that come in and they help us do our job. So say if we have to insert a PICC line on a patient, so it's a peripherally inserted central line that sits in the right atrium of their heart. And that allows us to give them more caustic medications or long-term therapy medications like antibiotics that might not be so good to put through a peripheral IV and have a high risk of, like, if it were to infiltrate or the IV were to go bad, that could have serious problems for them. So sometimes we will place those lines. And when it's an older child, understanding their developmental level and what they're cognitively processing is very important to the job, because we want our children to understand what's happening to them in a way that reaches them at their developmental level. So we actually have access to child life therapists. And I don't think that it's more tiring than adults, because sometimes there are adults that also don't understand everything that you explain to them. So it's a lot of continual repetition and really making sure that they do understand those things, as well as parents. Parents can be very helpful in explaining to their kids, like, those things, and just reinforcing that, it's okay. This might be a temporary thing. So it's not too tiring at all. I do have tips and tricks for nursing school, but just in terms of, like, the time that we have, you are more than welcome to reach out to me afterwards. I'll touch base on those. But I would have to say that the most challenging part of nursing school was the time management. There was a lot going on for me, at least, as a sports athlete. So really just budgeting time and allowing yourself some grace to learn the topics that you needed to learn and retain that information. It's difficult. It's a lot that's crammed into just 4 years. And even if you're doing your ADN, it's the same thing. You have 2 short years to get all these things in order and understand them so that you can provide baseline competent care to patients. So I think just giving yourself some grace in learning that is super, super important. And did it come naturally educating your patients as I progressed through my nursing career? So actually educating patients was very, very difficult at first, just because in nursing school, I was the one being educated. So I never really got the opportunity to return and educate patients as much as I had wished. That being said, I did take a nurse residency course, and that was offered through the hospital that I initially trained at. So I took an entire year. I had a class a month. They taught me, like, all about, the ins and outs of that healthcare system and how to navigate it as a new nurse. So that was insanely helpful. And since then, I've taken, like, preceptor courses that have really helped reinforce education and teaching points. And also there's a really nice like database within our healthcare system that has educational materials already created for you. So you're able to go in and say, my kid has a G-tube. I need to teach this parent how to use it and how to administer medication and feed through it. I can go in and type in G-tube, and boom, the absolute printout for them is there. I can sit down and then I can do the hands-on things. So I think those are all excellent questions. And then in terms of just timing and getting along with our case study, I will go ahead and skip on to that. So those are excellent questions. And if you have any more, just save them for afterwards and we can chat, since we only have an hour. So the case study that I decided to do with you guys was actually a cardiac kid. And these are kind of the kids that I'm a little bit more comfortable with, because I take care of them a little bit more frequently. And I specifically chose a child with a coarctation of the aorta, not only because, I've seen a handful of these patients, but also I had a friend whose child had this defect. And they were kind enough to actually share with me photos of their experience and their surgical process, just because I'm obviously not allowed to take photos of my patients. So there will be cute photos of him in here. And I hope that that will kind of give you a better picture of what we see on a daily basis, and also just kind of talking you through how to manage them. So let's go ahead and we'll get started with that. Just looking at like this slide and giving you a basic anatomy review. I'm not sure like what your basic understanding is of the heart, but basically that's our organ that pumps blood throughout our body, and it's responsible for all of that. And just looking at this diagram, the normal anatomy, and I hope you can see my cursor, what's in blue for the structures, those are structures that carry deoxygenated blood. So right here you have your SVC or IVC and your SVC. So those drain deoxygenated blood from like your head and your lower body, and then it comes right in here to your right atrium. It then passes through your tricuspid valve into your right ventricle, and that fills and gets pumped out through your pulmonic valve. And the structure right here is your pulmonary artery. So those take blood away from the heart that's deoxygenated, and it branches into two and actually goes to both of your lungs to become oxygenated. It then, once it's oxygenated, comes back through these little red tubules called your pulmonary veins, and comes back into the left atrium. That oxygenated blood now drops down through the mitral valve into your left ventricle. And this is kind of the powerhouse of your heart because it is responsible for pumping that blood out of the aortic valve into your aorta and out to the rest of your body. So that's, just little basic anatomy right there. And looking over, sorry, I got to move things around a little bit. Looking over at what a coarc is it actually means a narrowing. And typically that happens at the aorta. So if you look at the structure at the right, everything else looks pretty normal. And then you see this little narrowing here in this giant vessel. The little arrow that it's showing is a patent ductus arteriosus, and that's actually a normal thing to have, especially for a newborn baby, just because it's part of the fetal circulatory system. And typically in a newborn, it either closes right there at birth or takes maybe a week or two to close on its own, and is pretty benign. But in this case, it's very important that they have that because having this narrowing here in your aorta has pretty detrimental effects, especially in our newborn. So as far as what the coarc is it's the narrowing in the aorta, and you have it most of the time a PDA present. There are 3 different classifications to this defect, and that just relates to where the stenosed area is in the aorta, but I will not dive into that too heavily. Typically this happens in about 1 in every 2,000 births, and it accounts for about 7% of all defects, congenital heart defects. Males are actually more affected by this defect than females, and they're still not sure about what the etiology is because, it can be isolated or actually in conjunction with other defects. So right here you have kind of like a left heart to right heart shunt because the PDA is open, and the PDA, you're depending on that to allow more of a pop off of pressure within the heart. Because what the narrowing does is it actually causes a backup of blood flow into your left ventricle, back out into the heart. So having that PDA allows a little over circulation of blood to get back through and go back to the lungs, which is more of like that area of low pressure. So unfortunately, you just get this overcirculation of the lungs, which we'll get into more of like the symptomology, but and what we see when a patient presents with this. But they fall into two groups. Either we find this out pretty soon after they're born, or sometimes, depending on the severity of how narrowed that area is, we might not know until later in their life when they develop a little bit worse symptoms. So in the case of our little study today, this is my friend's baby, awful cute. He was full term, so it's 37 weeks, and this is him actually right just at the cusp of 2 days of life. And if you're looking at him, he looks pretty good just from a picture standpoint. He's got a little bit of acrocyanosis to his hands and feet, which is normal in most newborns. Kind of like a little reddy pink color, but overall, just looking at him from a picture here, maybe not too concerning for a newborn. But in terms of his course, he was transferred from an outside hospital. I had kind of like bad feelings about him. He had increased work of breathing. He had difficulty feeding and vomiting, and those on their own individually are not concerning most of the time, because as a baby they're switching over to their normal circulation instead of mama's circulation. So their bodies sometimes have a little bit of figuring out to do. But as far as backstory, uneventful delivery, no problems there. Wasn't prenatally diagnosed with anything and had all the prenatal visits. And then no suspected abnormality at birth. So that was kind of his course. It just was those three things that they were concerned about. And at the hospital that he was born, they were not equipped to really deal with a newborn that, was having issues. And just kind of switching on over. Initial impression of him as he was transferred over to a new facility. This was kind of just his picture. He had a slight increase in his temperature. His heart rate was 200. Of note, his blood pressure in his upper extremities was way higher than in his lowers, which is not normal. Normally it's the other way around. Sometimes your upper blood pressures blood pressures in your lower extremities are actually a little bit higher, and that's just because of the plumbing and how it has to work to get back to your heart. So that right there is concerning. His cap refill, which is when you press on someone's hand or on their heel, it's how quickly the blood flows back into those tissues. It was very delayed at 5 seconds. He also had decreased femoral pulses. So as we were feeling around, his femoral pulses, which normally, since they're central, they should be pretty strong because they're closest to your aorta and the left ventricle, that is your powerhouse of your heart. He also had a little bit of hepatomegaly, and that's where your liver is a little bit more distended, and on him, his liver would be right in here. So it was dropped down just a little bit. And he was very, very tachypnic, which means that he was breathing fast, about 80 times a minute, which is pretty fast for a newborn. We talked about the cyanosis. You can't really notice it here in this picture. And cyanosis is really just a bluish discoloration, and typically refers to them not getting enough oxygen. And speaking of that, his saturation levels were about 88%, which is below normal. We don't want our kids there. We typically want them, 90 to 100 is normal, but for kids, we definitely want them around like 94 to 100%. And when we took some labs on him, his sugars were low, and his blood gas was mildly acidotic. So right there, looking at him, concerned. From a nursing standpoint, I'm concerned about him because when we talk about children and their respiratory status, they will keep on, and then all of a sudden they won't. And that's when we have a real emergency. So for him, just doing a quick assessment, like our ABCDEs, we're thinking about his airway. Do we need to intubate him? Is he in a point where he's not sustaining his own airway? In the meantime, since his saturation level is low, throw a little bit of oxygen on him. He has a nice little nasal cannula in his nose, giving him a little bit of oxygen and some wind. And then see with his breathing, it's like we have the potential to intubate him depending on what his blood gases do. And that tells me about what his kidneys are doing versus what is his respiratory standpoint and how that all comes together. So those are how we decide, what respiratory support they might need or might not need. And then as far as C for just our access points and our circulation, what's most concerning to me is his perfusion state. His blood pressures are wonky. His cap refill isn't great, which tells me that, his heart's probably working a little bit harder. His heart rate is definitely up. And there are a couple of things that we need to rule out to make sure, is this, is he septic? Does he have a metabolic disorder? Or does he have a cardiac problem? And just based off of looking, at his perfusion state, I would say that even with the fever involved, he probably has a cardiac problem. So there's a couple, differentials that we have. We definitely want to correct some things for him, get him some IV access, which looks like he has one in his hand. Give him something to replace the hypoglycemia because kids, their metabolic rates are actually pretty high. So their demands and their need for sugar, we need to supplement that because this is a child that I don't really want to feed right now. When we feed kids, we actually increase, the demand on their heart to feed and perfuse their gut so that they can digest it. So for him, he probably wouldn't be eating at this point. We also want to take pictures, of his chest, rule out anything. Is anything wrong with his lungs? Does he have fluid on his lungs for any reason or another? So you'd probably get a chest x-ray in there to look at that, as well as, he's got little EKG stickers on there, and that tells us about the electrical activity of his heart. But we might also want to grab like an EKG to really see what the different electrical pathways of his heart and what they're doing. And so with him on his chest x-ray, he actually had an enlarged heart. And what that means is that he probably it's working a little bit harder than it's supposed to. And when you have a backup of pressure in the heart, that's what happens. Your heart has to work harder. And if you think about, lifting weights, when you're working harder and you're growing your muscles, that's unfortunately also what happens to your heart. The muscle grows and becomes distended and not pretty anymore. And so his chest x-ray also showed like a little bit of haziness. And like I said, with the small PDA that, gave him a little pop off to recirculate his lungs from that pressure. That's the effect of that. He gets an overcirculation of his lung fields and the blood flow there, and that causes a little bit more fluid to show up on his x-ray. So from there, just based off of the decreased pulses and perfusion, he would get like a TEE performed, and that is probably what would definitively show what's going on with him. So in his case, he actually did get intubated prior to his surgery. So this is him, and I have a little dino there just to protect his identity. But he did get intubated because he was not able to withstand his own respiratory support. And, that can be viewed as a bad thing from a parent standpoint. But just knowing the nature of his disease and how kids process that and can respond to it, it's in our interest to actually control his airway for him. And knowing the nature of this defect as well, and probably the need for repair, they're going to have to do that pretty early on. So he did get intubated. They decided to put a central line in him prior, so that's why he has that little mesh netting that's there on his arm. That's actually where his line was. He also has a small line coming out of his belly button, and from the looks of it, just because this wasn't a facility I worked at, it looks like an arterial line. A lot of newborns, we actually put their arterial lines in their umbilical cord. So you have, your umbilical artery. So we can measure his blood pressure pretty closely, and especially in a cardiac kid, that's super, super important. So preoperatively, he was intubated, he had lines, kind of medications that we think about for these kids. Their fluid balance is very important. So if we fluid overloaded them, that can have really negative effects on their respiratory support. So he was probably controlled with diuretics to make sure that he was peeing appropriately and getting fluid off of him. And we were probably minimizing the majority of the fluid that he was getting. So he was getting just the bare minimum he needed to be in a happy state with his heart and his heart function. We also commonly use a drug called milrinone in children that have cardiac defects. And what that drug allows the heart to do is just really fully relax and fully contract. I think 100% of our cardiac kids are on milrinone before, during, and after surgery. And that is something that we eventually wean off because it's only an IV form. So it's not something that they can go home on. The other thing to consider, especially with this defect, is PGEs or prostaglandin. And what that does is keep that patent ductus arteriosus open so that if that were to close in his circumstance, he would have a worsening of symptoms more than likely. So we want to keep that open up until we repair. Like I said, we've managed his airway, his fluid balance, and now the consent portion and really educating families on what is this defect, what is surgery going to look like for him. We're doing all of his preoperative management and stabilizing him while he's in our unit. So that's a really important part, is just, keeping families up to date on them, and that they understand, what is his life going to look like? What are the risks? What are the benefits to getting this surgery done? And just really hammering it home that they understand what's going on with their child. This can be super scary for a new mom who's just given birth, who is dealing, with her own health in her postpartum period. So there's a lot to consider and a lot of resources that we get involved to make sure that these families are really cared for appropriately. Kind of cycling into, he actually ended up getting surgery on day 3 of life. So really, really big surgery for, just a very young patient, but completely manageable. Again, he had the breathing tube in, he had the ventilator breathing for him, had sedation medication on board to make sure that he was comfortable because the breathing tube can be very stimulating. So we're very cognizant of if our patients are hurting. Again, they had probably lined him before he went down just because of the need to start prostaglandins. Those are something that you don't really want going through a peripheral line. For this repair, you can, depending on the degree and where the narrowing is in the aorta, sometimes they have to do an open chest procedure and then they'll close the chest, or they can do it as a left thoracotomy. So the patient will be lying on their right side. The surgeon will make an incision through the side of their rib cage, just under their scapula, and go in and repair the defect that way. And basically what they do is they just, they can either stent the area open, or they can, make a snip and reconnect everything so that there is no longer that narrowing. It really just depends on the patient and the degree and what the surgeon is thinking as far as the repair. But we get all of that information after the repair is done before they come up to us so that we have a better understanding of how we need to manage them after their surgery, which is closely monitoring. Like every hour, we're doing like almost full assessments on their perfusion status. Blood pressures are monitored by arterial line. So it's pretty invasive. We can do all of our lab draws off of those. And just we trend things. And in the post-operative period, I'm really managing, where is their heart rate? Where's their blood pressure? How is their perfusion state? Are they peeing? Are they starting to not pee? Those are all things that I'm thinking about. And we manage them with vasoactive medication like epinephrine to make their heart rate and blood pressure go up. We give them fluid back and replace electrolytes that often get depleted because of the surgery. And then, as they come out of their postoperative period, probably for especially a coarc, it's mostly they'll stay intubated for maybe like a day or two. It just depends on each child and how they're doing. And then we'll begin to start weaning the ventilator and testing them to see if they can really breathe on their own, and start de-escalating their care. So this was his room at the hospital that they were cared for. So just a idea of the kind of pumps that are in there. This might have been pre-operatively because I know at least for the coarcs that I take care of, I have quite a few more pumps. But it just depends on what the facility and what their standards are for caring for these patients. So just slightly moving on. Here is this cute little peanut. He got his breathing tube out. I think they said it was about a day or two after his surgery. So he's still got those crazy lines coming up out of the top of his blankie. He's on a little bit of low flow nasal cannula just to give him a little whiff of oxygen. And then down at the bottom, you can see that kind of pinkish tube. He did have a chest tube inserted after surgery. And a lot of our kids have that. And that's just to make sure, there's a little bit of oozing that goes on with the tissues after they're in this inflammatory state because we've gone in there when we've mucked around in their chest. So the tissues will kind of ooze and release a little bit of fluid. And we don't want that getting caught in their chest. So that brings some of that fluid out. And as the consistency thins and the output decreases, then we can move to really replacing rather pulling those tubes out. And typically that's pretty uneventful there. He had a left thoracotomy incision. So that's kind of what it looks like afterwards. It's pretty big and gnarly looking on him because he had a little bit of drainage. But the dressing over top is a Dermabond Proneo. That lasts for about 2.5 weeks on there and then comes off on its own. And I haven't seen him since, but I'm sure his incision is actually rather small now and he's grown. So, and is in a much healthier position. So, things that, we really worry about in these children after is that, they can develop pneumonia from being on the breathing tube. They can still experience cardiac failure afterwards, depending on, how much stress their heart was under. They have the risk for pleural effusions, which is, little pockets of fluid that fill up in the lung space that unfortunately need to be drained by placing a chest tube. And that's just the nature of, the volume that we have to give back to them to sustain them after surgery. They have a risk for lung collapse. They can have like a pneumothorax, especially with having the chest tube in their side. So this is why they're in the ICU. We're monitoring all these things like 24/7 and really noting any minor changes and continually talking with our team so that we can make better care plans and adjustments to get them off of the ventilator quickly and hopefully out of our ICU and de-escalated appropriately. The other thing that we worry about with this particular defect is a chylothorax. Because of the nature of where on the aorta that defect is, it actually comes out right where the lymph system is. And messing around in that area to repair it, sometimes damage happens to that lymph system. And as soon as we start to feed them, they have this intense dumping of milky, like fluid-like stuff coming out of their chest tube called chylus. And basically, it's the fatty acids from the lymph system that are being dumped into that chest tube because there's an injury at that area. That in itself requires extensive management afterwards. I can't say like how prevalent it is. I don't have particular numbers, but it does happen. And that can be a little bit devastating because sometimes we do have to switch their formula over to like a monogen. And so moms that want to breastfeed, that can be very hard for them to do. But that doesn't mean that they won't breastfeed again ever. It just, in extreme cases, it's been like 6 months before that happens. Afterwards, this repair, it's pretty straightforward for them afterwards. Most of the time, they're seen by a cardiologist. This lesion does not come back majority of the time. So they just have to have, well child visits and cardiology visits afterwards just to make sure that they're doing okay. And so I know that that was a lot. And so I'm totally prepared for any questions that you might have or questions that you have about this particular type of patient. There was a question back referring to just like my nursing career, if I had people in the course transferring from community college. And yes, I did have nurses that transferred in from a previous community college setting. I also had advanced practice or accelerated BSN. So those are people that already had a bachelor's degree and now they were coming back just for nursing. So that's a 2-year degree that allows you to get your BSN if you already have a bachelor's in something else, like maybe communications or something like that. So those were the questions that I have. No questions about a patient with a coarc? What? Well, if that is the case, I did have just one more slide, just talking about, what I wish, if I could go back in time, just like advice for students based off of my own experience. My number one is always shadowing medical professionals. So for those of you that are here, I'm super excited to kind of share my journey with you. Be vulnerable and ask questions. The world of medicine is very vast. And I think if I had known a little bit more about certain things, maybe my trajectory in my career would be different. However, I'm super happy with where I am right now, and I'm happy the way that my life, has come together. But also just picking a school and a path that complements who you are. I've been seeing a ton of kids that are, they're very interested in medicine, and we need doctors. But I want you to think about choosing a path because it fits who you are and not because you think that you're supposed to do it. Because what the thing is that it's your life, and you got to be, at the end of the day, you got to be happy with where you're going and who you're becoming. So just always considering that and always checking in with yourself and being like, is this right for me? Am I doing the right thing? Does this make me happy? Am I going to be successful in this area? And relevant life experience. A lot of sites and Google searches will tell you, oh, like get your CNA, do this, do that. And sometimes those opportunities aren't always available to everybody. So I don't want anybody to fret and think, oh my gosh, because I don't have like my CNA certification, and I don't have that experience, I'm not going to be marketable and a job will overlook me. I don't think that is the case at all. And especially in times like this, it's very hard to get into those areas. So relevant life experience, it could simply be that you're hosting, I used to work at Outback. You could be hosting and learning how to communicate with people and provide things for them. Because, nursing, it is about being in service to others and being able to communicate with them, and give them the things that they need. So, if you're a host, if you get your EMT certification like I did, although it's not nursing, it still gave me exposure, to different types of patients and emergencies. I also would just recommend really hitting the books hard. There's like there It's very difficult, to make time and to not cram and to give yourself, some grace when you're studying. But don't let that fall on the back burner, because the information that you learn now will serve somebody that's in need of your services later. So the dedication that you put forward to learning that material and actually understanding what's going on with your patients is very, very important. And it could change somebody's life because you noticed something that somebody else didn't. Um, and then if all else fails, and find a mentor. Think about where you want to be in your life, and if there's somebody that's where you want to be, reach out to them. Professional sites like LinkedIn are becoming very, very popular. Back in the day, I created my own LinkedIn, and since then have really adapted it and been able to connect with a lot of different people. Even though I'm not looking at going anywhere, or changing jobs, it's still nice to have that professional connection, because when I do have that opportunity, or have that desire to keep moving on, I have a profile in a professional setting virtually that I can reach out to people. So, and if any of you are interested in having a mentor, especially for nursing, you guys are more than welcome to reach out to me by email. I do have social media sites. So, you are more than welcome to follow me on there, and let's stay in touch, because I would love to hear about your journey. And just see where life takes you. And if I can help you in any way, my door is always open.
All right. Thank you so much for all your time and all your great information and insight into nursing. We really appreciate it.
Absolutely.
Yeah. So yeah, it doesn't look like there's any more questions in the chat. But yeah, so for everyone on the YouTube live, I have posted a link for you to fill out for the Google Forms for you to fill out in order to receive your shadowing hours. It will close at 4:20, so make sure to get it in by then. And it's basically asking specific questions about what Katie went over, and like specific points that she covered. So try to get above an 80% score on that in order to earn your shadowing hours. But yeah, thank you so much for all the information. I really appreciate it.
Absolutely. It was really good talking to you guys. Thanks for having me.
Oh, thank you.